So in addition to myself, Nadine Hachash-Haram, our consultant plastic surgeon, Mia Stain, who is a consultant dermatologist in the HS service. We have Arlene Maguire, who is our very wonderful pharmacist that's in the HS service and across the medical dermatology services at Guy's and St Thomas's. And we have Debbie Brown, who most of our HS patients will definitely know. She's a wonderful clinical nurse specialist who's doing a great job over very many years looking after our HS cohort. I don't know if Mark Turner, our clinical psychologist, is also, oh great, hi Mark. So Mark Turner is our clinical psychologist who works across the medical dermatology services, and he looks after the mental health of our HS cohort. So we all work together to help to improve things and get patients better controlled. So I'm just going to look over to the questions. And I might direct them to some of the panel members if that's okay with everyone. So Debbie, I don't know if you want to take on this question. So do you have any advice for HS sufferers on how to manage the various stages of wounds?
Well, you did mention, Mia touched on dressings, and usually in the early stages of HS, you don't need all of these big bulky dressings. I think most of our patients, the main problem is having dressings stay in place, whether they are big and bulky or whether they can use lightweight dressings. And there are many options to get these dressings to stay in place in the axilla or groin area. Something as simple as just a plaster with an adhesive border can help enormously in the early stages. The only thing I'd recommend with that is that you use a non-sting adhesive remover before you remove it, and that will help protect the surrounding skin that isn't infected, because sometimes with long-term dressings with adhesive borders, patients do tend to get irritation around the dressing itself, and that can be an issue. As far as securing dressings to the groin and axilla, things like cycle shorts really work well. If I'm allowed to say, Primark has a bunch of very cheap cycle shorts that a lot of our patients find really good for holding dressings in place, especially the buttock areas. There's something like £2.50 a pair, or old leggings that you can cut off. Of course, you can go, there are more expensive options. There's a company called Snag Tights that do shorts called Chub Rubs, and they're very effective as well.
That's great, thanks Debbie. Nadine, if it's okay, just a comment. Is it common for HS lesions not to heal well after having I&D procedures?
So it's not so much, so I would sort of clarify by saying we don't automatically go every time there's a lesion in an acute flare-up of HS and perform an incision and drainage. We really reserve that to if someone has a really, quite tense abscess that is inflamed, red, you see it, it's all swollen and is extending beyond now even the borders of the HS disease itself. That means, there's no amount of medication alone that's going to clear that out. We need to de-roof it and get the pus out to ensure that there's a chance for that to settle down. So often we're going in not with the intention to cure the HS or even thinking about future surgery. We're thinking about in that moment in time, how do we decompress quite a tense and difficult area that's infected and inflamed. Always the first line of action in any HS patient, even with an acute flare, is of course medical management, and try and see if that in and of itself, some antibiotics and others will sort it out. But that shouldn't preclude you from any future reconstruction or excision anyway. So if, for example, you have an abscess in your axilla and your armpit, and we have to make an incision to release and decompress the abscess in an area that's got diffuse HS, we would still then opt for at a later stage when everything is a bit more quieted down and under control to cut that whole area out and consider reconstruction for that area as well. I caveat all of that by saying every case we have to take on a case-by-case basis. These are general themes and thematics of what we do, but we always consider it in the context of the patient, how well they are, how unwell they are, where the abscess or the disease is sort of extending to, and then what are all the options in front of that patient. We discuss it with the patient, going through risks and benefits of each one.
That's great, thank you. I might just quickly answer some of these. So I'm prescribed doxycycline for a week at a time for flares. Can I approach my GP for longer treatment cycles? And yeah, doxycycline can be given by a GP practice, so that's usually no problem. Someone's written about being worried about getting pregnant. We don't have long-term data regarding pregnancy and whether HS gets better or worse, but most patients do get better during pregnancy. Arlene, I wonder if I can come to you. There's a question about how we can, how they can have Hydraware prescribed and whether that would be available. Would it be through the GP or through specialist services?
Hi, Ellie. Yes, Hydraware is an interesting one because it only recently became available on the NHS. So it's just entered what we call the drug tariff, which is like the Bible of things that can be prescribed. It's a little bit complicated in that at the moment, for many areas, that still has to be recommended by a specialist, so a specialist dermatologist. So it might not be necessarily available in your local area or directly from your GP unless that's been recommended. We're working on that in our local area at the moment, for example. So I think because it's still relatively new, it may be a bit tricky to access at the moment, but hopefully that it will change. And it's definitely worth having the conversation.
Mia, I'll just come to you for a few of the questions. So what is the prevalence in men versus women? And are there any comorbidities associated with HS?
So the prevalence kind of differs depending on which studies you look at and which populations you're looking at. And when you're looking at comorbidities, there are some that are commonly associated. So we often find that HS coexists with acne. It can coexist with inflammatory bowel disease, so things like ulcerative colitis or Crohn's. We often ask our patients about joint pains and arthritis. And then we often find that things like polycystic ovaries can coexist. And so while these things aren't necessarily directly linked, we do find that we get them with increasing frequency in our population of patients who do have HS. And that's why it's really important when you are seen by your GP or by your specialist doctor, that we try and address all the parts of your general health and your medical conditions and not just focus on the one, because that will change how we can treat you.
Thanks, Mia. Mark, just coming to you next, there's a question about sort of psychological comorbidity associated with HS.
So there's very high prevalence of both depression and anxiety in patients with HS. Even higher than in many other dermatology control groups, as well as a very significant impact on quality of life. And there's also a high prevalence of severe and enduring mental health problems as well. So when we deliver our psychological support, we use what we call a stepped care model, which offers things like self-help material to people that have lesser an impact, through to a specialist psychological support pathway delivered by myself and up to use of liaison psychiatry for contributions there
Mark,
as well.
Thank you. Just another question for you, Mark. If my HS makes me depressed, what help is available other than antidepressants?
I guess that depends what clinic you see. Obviously within our specialist clinic, we have a pathway where I offer psychological support using frameworks like cognitive behavioral therapy and acceptance and commitment therapy, which has a very good evidence base for chronic pain. If you aren't within this clinic, within the clinic here at Guy's, then you should speak to your GP and think about options in terms of whether or not you'd like to access primary care psychology, where you can have one-to-one CBT. You just won't have it with someone that has a great knowledge of HS, unfortunately. Or if you have a higher level of need, your GP can help you access secondary care mental health services as well.
Thanks, Mark. Arlene, a question for you. Can you suggest pain management options if paracetamol just doesn't cut it?
Yes, so we know with HS that there is obviously a strong element of pain, and some patients really struggle with that. And I would say that within the NHS, we follow something called the pain ladder. So we obviously don't want people to be in pain, and we look at sort of using steps upon that ladder. There's lots of different agents that we could add in and try along the way and sort of build up till we get to controlling that pain. So that's something that definitely your GP can help with. Doesn't have to be a specialist. GPs are well versed in managing pain and will know about the pain ladder and can assess your type of pain, what, you know, how best to target it with all the different analgesics that we have.
That's great, thank you. We have had so many questions. So just to direct people, we're in the process of updating the Guy's and St Thomas's website with regards to clinical trial information. There is a link to contact the clinical trials team, and I guess just speak to your dermatologist or GP if you'd like to participate in clinical trials. I just want to really say thank you to everyone who's given their time to give this whistle-stop tour of new treatments coming forward for HS and how patients can help themselves and what they can approach their dermatologist or GP or healthcare provider with to hopefully enhance their HS management. Thanks everyone for joining, and I hope you found that useful.